Good morning, good afternoon, good evening to those who've joined us live, and for those who are watching it afterwards. I hope you have a good time listening to the recording. Um, I'm delighted to help moderate this session. You've heard these speakers already, and it'll be great to have a chance to get them interacting and hear what they think. Before we begin, my name is Peter Senior. I'm a professor of endocrinology. I look after people with type 1 diabetes, and I'm based at the University of Alberta in Canada. I'm going to ask our panelists to just briefly introduce themselves so that you know whose voice and face matches. And I'll go in no particular order. But let me begin. Justin, could you introduce yourself quickly?
Hi, my name is Justin Pinson-Stadler. I'm a clinical team leader in the Division of Diabetes, Lipid Disorders, and Obesity in CDER FDA. Pleasure to be here. Thank you.
Thanks, Justin. And Stephen?
Yeah, good morning, everybody. Stephen Carpin here. I'm the Senior Director for Regulatory Affairs with Breakthrough T1D.
That's great. Christoph, can I ask you to introduce yourself?
Sure. Christoph Tasto. Hi, I'm a statistical project leader in type 1 diabetes at Sanofi. Thanks for having me.
Thank you. And Helen?
Hi, I'm Helen Cullen. I'm a professor of medical informatics and epidemiology at the University of Edinburgh in Scotland.
That's great. Kimberly, you're next.
Hi, I'm Kimberly Collins, a senior quantitative medicine scientist at the Critical Path Institute.
And Colin?
I'm Colin Dine. I'm Professor of Diabetes at Cardiff University in the UK.
And last but by no means least, Joe.
Hi, Joe Hedrick. I'm the Executive Director for the Type 1 Diabetes Consortium at C-Peptide.
Great. Well, listen, thanks for warming your vocal cords up. Let's kind of jump into things and we'll try and have a dynamic discussion today. I'm going to ask perhaps, Justin, if you could begin. At the 2021 workshop, one of the questions that came up was, to try to address the relationship between C-peptide and A1C. And I think we've heard both from Kim and from Colin, summarizing some of the data that was published in 2023 by Peter Taylor, Kim, and Anna Lam were the first authors. They examined clinical trial data from a range of trials in new onset diabetes, and they described a relationship that seemed to be proportional. And then the individual level data presented by Kim seemed to confirm that. Do you think that's convincing? Do you think there's conclusions that we can draw from that?
Sure. First, I really like to recognize the efforts made by the Type 1 Diabetes Consortium in curating the TOMI T1D dataset. I think this is a really important advancement in the field. Now, I think the key question before us is the magnitude and uncertainty of the clinical benefit assumed from C-peptide if the clinical benefit isn't directly measured. I think the best way to estimate this effect is by taking advantage of randomization. To this end, I think the most convincing analyses that have been presented use randomization, such as Figure 1 from the Taylor et al. 2023 paper, and the new meta-regressions presented by Dr. Collins. In my opinion, the causal data show there's likely a shallow relationship between the preservation of C-peptide and HbA1c and new onset type 1 diabetes. Based on these analyses, I think there's a substantial trial-to-trial heterogeneity and overall statistical uncertainty in the magnitude of the benefit. From my point of view, from a benefit-risk point of view, I think it'd be difficult to interpret the clinical benefit from a study only reporting an effect on C-peptide without other trial data to contextualize it.
Kim and others for some time. Any thoughts or reflections on that?
Yeah, I guess the question really is, maybe putting it back to Justin, is what more would be needed? We've looked in some of the presentations, we've talked about things like quality of life, we've talked about insulin use. There's the challenge of hypoglycemia soon after diagnosis that begins to kick in a little bit later on. What do you think would be needed to add to this?
there's a question, there's a component of endpoints, and then there's a component of analyzing the HbA1c data that we already have, right? So as far as endpoints, I guess I could just take a big step back and point out that our draft 2023 guidance for industry agrees with inclusion of CGM metrics as key secondary endpoints supportive for glycemic control indication. That guidance includes our general recommendations to that effect. Now, and I've heard yesterday and today a lot of concerns about HbA1c and hypoglycemia and the feasibility of demonstrating those. I mean, we've heard lots of different ideas about it, but I want to make it clear that glycemic control isn't the only benefit for a new onset type 1 diabetes patient. We hear you loud and clear on that. I want to point out that we accept all clinical endpoints, which also includes markers of treatment burden. We're open to discussing CGM-based metrics or other treatment burden-related endpoints, such as daily insulin injections, number of correction boluses. Come talk to us about that. I think this is to really move this forward meaningfully. I think the community needs to come to us and discuss these issues. I mean, there's still some residual questions, right? Does the community think there's a role for treatment-based endpoints or treatment burden-related endpoints, such as daily injections? Are there existing tools that are face valid? I know there's pragmatic issues with ascertaining this data, right? It's messy to ascertain number of insulin injections and so on. I think some new technology might help there. And does this even solve our problem? So these are questions that I think the community is better positioned to think about and answer. And we look forward to talking to you about it.
Follow up, and I'm going to sort of turn to Kim in a moment a little bit, because I think you've wallowed in this data, Kim, and you've talked a little bit about sort of next steps in terms of multivariate analyses, because I guess one of the issues about the relationship between C-peptide and A1C is that there's a major confounder of insulin dose. And so that multivariate analysis, could help untangle that. So Kim, I think the question to you is going to be, am I right in those thoughts? And then perhaps back to Justin, do you think the multivariate analysis will add extra benefit, or actually do you think we still need to go beyond that? But let me ask Kim her question first before we come back to you, Justin.
Thank you. Great point, Peter. So yes, I believe the multivariate model can help strengthen the link between C-peptide and HbA1c. That type of modeling will be helpful for clarifying that
My attempt to fill in the missing word. Oh, you're back, Kim. You're just saying that you think it'll help sort of untangle the interactions between those terms, I think.
Okay, yes, sorry. So yes, I think that the multivariate model will help strengthen the interaction between C-peptide and HbA1c. With that type of modeling, it'll be helpful for clarifying that interconnectedness. So we have patient-level data from multiple clinical trials where each of these endpoints are collected. So with the multivariate model, we can answer those questions. The impact of insulin on HbA1c, impact of insulin on C-peptide, and the impact of C-peptide on HbA1c. And all of these interactions will come after we have described the univariate model for that endpoint, accounted for covariates. So I think a multivariate model will be very useful in how we interpret C-peptide and its relationship after accounting for everything else.
Great. So I just need to handle my sort of impatience because I'd like the multivariate analysis tomorrow. So I guess that will help clarify some things. I mean, it's not going to fix the heterogeneity in A1C between trials and between individuals within trials. But Justin, again, I don't know whether you want to comment about that sort of the multivariate model. Is that going to be a bonus feature, or is that kind of going to be fundamental?
Well, I see a lot of discussion about observational data that doesn't use randomization. but I don't see a lot of discussion in the community about the confounding variables. So to Kim's point, I think that's an excellent idea or way to go. Now, I think the TOMI T1D data set has kind of given us the gift of randomization, and I think we should definitely look very carefully at those data. But as supportive, like I think accounting for confounding variables and observational type analyses is definitely the right direction to go.
Okay, great. I'm going to sort of try and link up. So, Colin, I was actually going to come to you, and maybe actually, Stephen, you can back this answer up or provide additional data, because there was actually hope that the TOMI data set would actually have CGM data and that we'd be able to sort of throw that into the mix. But Colin, I don't know if you want to comment about, the CGM data, what we had and where it was limited to.
Yeah, I mean, there's been such an explosion of CGM data recently, but we had quite limited CGM data, and it wasn't of great quality in those older studies. In the data I presented, we looked at CGM in 2 other prospective studies, and bringing them together, you could see an association, obviously with HbA1c, but with C-Peptide as well. So I know there's been some concerns about the standardization of C-Peptide, but I think all studies going forward will have CGM sort of built into it. I just wanted to bring in, maybe I'm moving ahead too much, Peter, but the issue of longer term outcomes, which are difficult to do through randomization, and come to the observational studies such as those that Helen and others have presented and reviewed the DCCT data, that the more C-peptide you have, you do better in the longer term. How should we loop that in? Because these are going to be, 10+ year studies.
Justin, do you want to take a go at that one, or would you like to hear Joe's comment first?
Well, I don't think we have the requirement. I've just quick comment. I don't think we have a requirement to. We're asking for long-term outcome data. We're talking about intermediate term. I wasn't aware that long-term. I mean, of course, I would encourage, and I think our patients deserve long-term outcome data, but I'm not aware that that's a bottleneck. So that's my perspective. Thanks.
Okay, that's great. I mean, maybe I'll actually come to you, Helen, because I think Kim made some mention about the relationships between A1C and insulin dose and hypoglycemia risk and then potentially complications. And I guess maybe the question is, the data that you've presented, again, it's kind of observational. There's a prospective element to it. How robust do you think it is? Do you think there's any risks of reverse causation at all between linking, C-peptide A1C and long-term outcomes?
Okay, so I think the one useful thing to be clear about is differentiating between a mediator and a confounder. So in the paper that we published a few years ago on the 5-year follow-up of the STRN Type 1 Bio, we had the baseline insulin dose in there, and we also had baseline HbA1c in there. And the relationship between baseline C-peptide and incident complications over 5 years, in particular, I'm talking about events like DKA, hypoglycemia, and also incident retinopathy, were robust to adjustment for those covariates. In the presentation that we showed earlier today, I showed the relationship across 11-year average follow-up between your baseline C-peptide level and your incident hypoglycemia events. And those data adjusted for some of the primary covariates associated with C-peptide, notably age of onset and or diabetes duration with age, in these models. Actually, we have HbA1c data in our cohort. We get every HbA1c that's measured in the clinic, and by primary care on our patients. So we have thousands of HbA1c measures through follow-up. And if you put HbA1c into the models as a time-dependent covariate, it makes virtually no difference to the association between C-peptide and incident events. It literally changes. For example, C-peptide treated as a continuous exposure variable. It changes the beta regression coefficient by virtually nothing. Yeah, 0.0 something. Yeah, exactly. It makes very little difference. So now that said, I mean, we do see obviously as well a relationship between C-peptide and HbA1c, but it's curvilinear. Okay, so if you look at all the prospective HbA1c data in our cohort, you can see that there is a monotonic downward relationship such that the higher the C-peptide, the lower the HbA1c, and that relationship becomes steeper as the C-peptide is higher. Okay, so it's a curvilinear relationship that we see. And if you regress the data the other way around, yeah, you see, and we reported that in our 5-year follow-up paper, you can see that HbA1c is a predictor of your or is associated with C-peptide at baseline. So how do I interpret these data? First of all, I think that the relationship in the observational data between your C-peptide level and your risk of hypoglycemia and your risk of DKA is very robust. We have thousands of DKA events in this data set. Okay, we modeled recurrent DKA as well as time to first DKA. And we have thousands of DKA events, and we have hundreds of severe hospitalized hypoglycemia, which is the tip of the iceberg. So I think those associations are very clear and very robust. Now, the question is, how do you interpret them with respect to causality? Okay. And, I completely agree with Justin that always the best data for causal inference is always going to be randomized interventional data. Yeah. So the question is, since we don't have those data for long-term follow-up, how confident can we be in the observational data? My view is we can be very confident that if you have a higher C-peptide, you have a lower risk of DKA, hypoglycemia, and interestingly, a lower incidence of retinal disease. The question then is, how is that mediated? Is that mediated entirely through glycemic control? The fact that adjusting for time updated many variables counts, I should say, for HbA1c makes very little difference to that, tells me that HbA1c per se doesn't account for that relationship. Now, you can further argue and say, well, how good a measure is HbA1c of your excursions from hour to hour of blood glucose? And we know that that's imperfect, right, for sure. Okay. We are working very hard, actually, to try to get a linkage into our national data set of CGM data from patients. We're trying to work with the companies. There are all sorts of issues there to do with data privacy, et cetera, and also corporate concerns, et cetera. But we're working very hard to try to get those data routinely read in, if not continually, then at least a period snapshot at repeated times. And I think that's really, really important. And I think that actually the companies need to be really understand how important it is for them that actually big electronic healthcare databases can contain those data and make better inference. But that said, if you have a dirty measure variable, right, which HbA1c is, of your full glycemic excursion, and if you have a lot of it, like we do in our data set, and if you see such little impact on the regression coefficients, then that does tell you something, that it's very unlikely that having the full perfect data is going to completely abrogate those associations, the relationship we see between C-peptide and outcomes. I think it is a reasonable assertion to make that I would be very surprised if CGM data abrogated that relationship. So I think, you know, what we're seeing here is some more fundamental phenomenon, and some of it for sure can relate to the alpha cell as well. So I'll stop there for now.
That's great. Thanks so much, Helen. So there's lots in my mind at the moment, and I'm going to try and keep it relatively organized. So, I mean, I think the data you were showing, I mean, these are people who've got very, very little C-peptide relative to the new onset space, and yet you showed prevention or, you know, protection from hypoglycemia, you showed protection from DKA. And I think, Colin, again, the TOMI data set, we saw some evidence for protection from hypoglycemia. Again, was the hypoglycemia data robust? And then any thoughts as to why it didn't perhaps connect with quality of life in the kind of the data you showed, I think, from USTKID?
Yeah, so I think in the new onset space, there's relatively little hypoglycemia. And in the patients that Helen looks like, they're much further on. That's when the hypoglycemia really comes into play, the severe hypoglycemic episodes. And I think that's really the issue, that you're going to protect them down the line because you have more C-peptide, it's preserved for longer. It's going to be a benefit that will kick in 2, 3, 4, 5 years down the line, rather than necessarily in that first year.
Stephen, I thought I was about to come to you. I thought you might come in.
Yeah, I thought you might also. Yeah, you know, I think part of the challenges with the hypo data that's in TOMI was just how variable hypo was collected across the studies that are included there. A lot of those studies really preceded the kind of modern era where we have good high quality CGM data pretty ubiquitous in our patients, especially in clinical trials. And standardizing how hypo data was collected, how it was coded, whether or not it was collected as a adverse event versus an actual endpoint was a challenge for sure when we put together the TOMI database. And so I think that adds a little bit of difficulty then in how we interpret the data coming right out of TOMI on hypo. But I think what we do need to keep in mind is what we heard pretty clearly, I think, from Haley and from Julie yesterday during the patient discussion, talking about when they're low, they feel it. When they're high, they feel it. And those swings back and forth between the two is something that really impacts how they function day to day. Haley, I think, talked about the brain fog that she feels when she's low and when she's high. And you can kind of imagine if I'm going about my daily life, hopping on Zoom calls, doing work, playing with my dogs, you know, whatever it may be, if I'm constantly reorienting from feeling pretty brain fogged out to feeling relatively stable and then back and forth again, that's a pretty big disruption to whatever it is that I'm doing at any given moment. We don't, especially in TOMI, have that data in any sort of PRO or kind of patient experience that we can analyze in the same way that we've looked at A1C or hypo. That doesn't mean that that isn't a really important thing we need to be thinking about when we think about how all these dots connect in terms of the way it affects the way a patient feels or functions.
I mean,
Can I just sort of add to that? We don't think have a patient on the panel, but they also emphasize this thing of fear of hypos, that it can continuously, even when you're not hypo, if you've had several experiences, it just extends right through the day.
Yeah, and I think you know that the roller coaster is, you know, is an issue that's close to my heart, because that's the thing that many of my patients are dealing with. I mean, if it was stable, they wouldn't worry about hypoglycemia, but they're worrying about both highs and lows. And again, I was struck, Colin, that the USCID data, there wasn't really a really strong link with quality of life in that data set. But I think there's part of me wondering, and I'm going to come to you, Joe, actually, because the new onset people, you know, they've got more C-peptide than the people that Helen has studied. You know, they're impacted by their diagnosis for sure, but again, hard to measure with the quality of life tools. If we come to think about the transplant setting, and again, you presented some of that data, Joe, we've got people who've had no C-peptide. They then get pretty much a full complement. They then may slide back down the hill again to some extent. And I think that's where we're seeing really quite robust patient-reported outcome measures, quality of life data. Do you think that is a powerful connector between, C-peptide, beta cell function, and patient experience?
Yeah, so I think you're making a really good point here, Peter. Transplant can can be considered an intervention, right? Just like a drug in the new onset setting to preserve C-peptide. Obviously, the context is a little different. There's an additional potential confounder there in terms of the use of the immunosuppressive regimens to keep the islets surviving. But that might actually lead to an underestimate of, or rather an overestimate of how much C-peptide you actually need, because it could be generating insulin resistance. There's some data out there. So I think that's something we'd need to look at. But I think, yes, in terms of what a difference it makes for those individuals, I mean, I think that's pretty clear. But again, the circumstances are a little bit different than they are in the new onset set.
Although, sorry,
Yeah, go
I was
ahead.
just going to follow up and ask, I mean, some of the transplant data has begun to kind of suggest some thresholds that, if your C-peptide is above here, you can be off insulin completely. If your C-peptide is here, you're going to find it easy to get to target. And you don't seem to need very much C-peptide at all to get protection from hypoglycemia, which again would align with the data that Helen talked about.
I think that is a fantastic point. So I really liked the paper from Bidal et al. That was in 2023 Diabetes Care. So systematic approach using different methodologies to look at C-peptide, and then looking at what are the thresholds for each of those clinical benefits coming from transplant. And I think a couple of important points there, right? So it's not necessarily the case that a specific measure of C-peptide is good for everything, although they presented thresholds depending on what methodology you were using. But I think what it does sort of present is, okay, there's a potential framework here for us to be able to answer one of the other questions that came up in 2021, which is, okay, well, what are the thresholds of C-peptide that we can associate with any of these given benefits? And I think what I find really interesting, which you just pointed out, is the fact that what Helen was talking about in terms of the threshold needed to alleviate some of the hypo risk is low in the analysis that she's done. That's confirmed in these transplant studies. So, I think that also goes a little bit to maybe some of the causality actions, because you see that very, very quickly right after the transplant. This isn't something that you have to wait 10 years after necessarily to see. So, with all that said, some of the strongest data is coming from the transplant space, and now we have new data coming from the islet replacement approaches. We need to leverage that better, I think, to be able to help inform regulatory decisions. So that's clearly a gap that still needs to be addressed.
That's great. Christoph, I'm going to come to you in a second because, I've actually just been in an islet and stem cell replacement meeting the last few days, and a lot of discussion has been around, where CGM fits. And it seems as if time in tight range is something which an islet or a cell therapy can deliver really robustly. And that, will tell us a lot about kind of maybe clinical benefits for people. And I think where my head was going, Christoph, was whether we could think about sort of a C-peptide outcome and a time in range or time in tight range outcome or some other CGM metric. And, would it make sense to combine those as a kind of a composite outcome as we might see with cardiovascular outcome trials or renal outcome trials?
It's a good question. And I thought about this yesterday when, what's her name? Sorry, Laura Hickman from FDA talked about also the strategy to have a hierarchical testing. First test, for example, for the similarity in HbA1c effects, and thereafter test other endpoints. So I think a hierarchy would make sense in a way to come away from only looking at one single endpoint, but rather thinking in terms of different endpoints and combine them in an appropriate strategy. Let it be hierarchical, or let it be, for example, a more sophisticated alpha testing. But from a statistical point of view, to a composite endpoint, I'm a bit hesitant because you tend to do a composite endpoint when you have low power. We saw in the talk by Joe that we have sufficient power for a reasonable trial in C-peptide. So also the interpretation of a composite endpoint is difficult when it comes to the results interpretation, but there may obviously be reasons, for example, in the islet transplantation, that there is the mode of action or the population, there is a need to combine to a composite endpoint. I would like to come back to the discussion before when we discussed the gold standard of a randomized clinical trial. And I agree with Justin that we have this randomization in the TOMI data, which is potentially even growing the data set, but we also have to account for the lots of data that we have in the registries, and we have the causal inference methods at hand. We have the target trial emulation, and I believe that Helen is going here exactly the right way, and we should continue here to also make use of the existing registry data in addition. Thanks.
That's great. So thanks for clarifying my kind of understanding. Certainly in islet transplant, the kind of this composite of glycemic, A1C at target without severe hypoglycemia. You can see why that's highly relevant for people who've started with hypoglycemia. But I think what I'm hearing is that a hierarchical testing strategy might actually really add some advantages. I suppose my naive question is there any advice about, what should be the first thing to be tested? Are there any pitfalls that you've seen in other trial designs where people they picked the wrong primary endpoint, and all of the subsequent analyses would have been positive if they'd resequenced them? Or is that something that we need a crystal ball to work out?
It's always a mixture, I would say, of what you want to show. If you are sure about, for example, the non-inferiority in HbA1c, you can put it first because you're sure you hit it and it's a check mark on it. But if you have to hit something very important, very needy, then put it first, even if the risk is higher. So it depends on the risk that you want to take, on the endpoints you want to show. And it's always a debate also with the agency, I would say, what makes sense in respect to the hierarchy.
So Justin, I'm going to come back to you because I think you have actually been really very clear in terms of, you don't dislike C-peptide, you quite like it, but you actually would like to see it bolstered by some other things as well. And again, it seems to me that CGM might be one of those elements. I don't know, you've been listening to kind of the discussion so far. Has that kind of enlightened you further or raised further questions for you?
So I agree with Christoph's point about, or hesitation with composite endpoints. I'm not sure that's needed here. I think there are methods to preserve type 1 error while also being flexible, and that other endpoints may or may not be born of show an appreciable effect size. For example, the home testing procedure, right, or like top down or bottom up approaches. We're open to those sorts of approaches here at the agency. Thanks.
Okay, that's great. Sorry, Cullen.
Okay, can I just come back to you on quality of life and, point out this issue that quality of life is associated with glycemic control, and glycemic control is associated with C-peptide. Now, it was just generally our view that this has not been widely collected enough, that we need larger data sets to show it. But, there is a strong suggestion that this is, something that is going to be associated. It does have an intermediary association. So I just trying to clarify whether this is because it's trying to reflect the patient experience. Is this something we need to collect more data on?
Joe, jump in. I was going to say something, but Joe, you go
Well,
first.
I'm just going to add on top of Colin's comment and ask Helen a question too. Was there any quality of life data collected in the Scottish cohort or the cohorts that you've been examining that we could look at?
We do have some measures in the data, and we haven't looked at them as yet in relation to C-peptide. But they are, I would say, very crude instruments. So we have things like the HADS questionnaire. We have some other scales, psychometric scales that, in my view, are really they're really more for capturing anxiety and depressive symptoms than they are full, what I would call PROMS measures, patient-reported outcome measures. It is something that I have been trying to urge my colleagues to get onto the our database, because we actually do have a patient-facing portal where patients can actually enter their own data. And so I'm trying to push for that. The issue has to do with really just prioritization, because there are so many variables that you want to collect. But I have been trying to push the message that we really need PROMs, that it's absolutely vital. This isn't some sort of luxury item. It's as fundamental as, as capturing the HbA1c. So hopefully over the next year or so, we may have such items introduced. But in the meantime, it probably is worth our while to at least look at some of the dimensions in some of the psychometric questionnaire data that we do have.
And I'm going to come to you in a second, Stephen, and then Justin. There was actually someone else has presented this week looking at quality of life among people with different ranges of function after an islet transplant. And it's kind of interesting that people whose transplants are working well, they feel great, and their PROs are all green. If people have lost the function of their transplant, there's a number of things which are back, hypoglycemia, fear, and things like that. But actually, there was an intermediate group, and they seem to be in the worst situation where they were worried, they're more anxious because, they couldn't grieve the loss of this thing because they hadn't lost it yet. And I think I wonder a little bit with the new onset people, they've had to grieve the diagnosis of diabetes, but they may not fully know all of the challenges that may lie ahead, which again become more clear as the honeymoon period ends. And the final thing I was going to say was just we actually did a workshop that Breakthrough T1D hosted with patient partners, talking about PROs and whether they're fit for purpose. And the patient partners were saying, it's really burdensome. Some of these questionnaires are so long. And so there are some newer methods to collect in the moment information that I think would be very helpful. Stephen, did you want to come in? You've come down on your hand.
Yeah, still some thoughts. So I think, the kind of approach of taking a PRO measure, whether it's a new one that we then validate, connect it to what's happening in these clinical trials, or take existing measures that are maybe good enough for us to make some of those conclusions. I mean, it's certainly one way to think through this. Breakthrough is leading a pretty big effort in PROs to get at this exact question now, but we're also in the middle of a patient preference study trying to understand from the patient view, what are the risks and tolerances, the risk tolerance for disease-modifying therapies, cell therapies as well. When we talk to patients about what are the potential benefits of a DMT in the new onset space, we hear them talk about the exact same things that we heard, again, from Julie and Haley yesterday, right? Extending that honeymoon period, making that transition period after diagnosis just a little bit easier, a little bit more predictable day-to-day, a little bit more stability while they adjust to, as you say, kind of preparing, grieving the loss of life before and preparing for life after diagnosis. We know that's really important. Justin, and I see your hand is up too, so maybe I'll swing this over to you here. But you mentioned the phrase face validity earlier, and I think about it takes a long time to develop and validate PRO measures, and we're maybe behind the ball here when it comes to doing that, especially when we think about in a way that supports regulatory decision making. Is there, is there a way to kind of connect what we know about the disease? I think Carmela framed this really nicely yesterday. At the time of new onset diagnosis, we're in a position where we have a microorgan that is still functioning, but it's failing. We can intervene to preserve that organ's function at least for a little while, but we don't. And we wouldn't even think about that in any other disease if we could preserve any other functioning organ from losing that function. So is there a way to think through, the CGM metric point that we talked about before is sort of the best direct reflect measure we have of what that microorgan is doing? Can we connect that using your phrase there about face validity of what that actually means, what that tells us, connect it to what we hear from patients, from their experiences, and then use that as our sort of path forward to overcoming the challenges we're faced with?
Thanks.
Yeah.
So can I respond?
Yes, please.
Yeah.
I was coming to you.
Thanks, Stephen. We're teleconnectically connected. I was having the same thoughts. So I just step back for a moment. We're interested and open to a PRO or clinical outcome assessment as far as measurement of treatment burden and so on. But those are burdensome, and we hear you. They're not easy to use in a clinical trial. They're difficult to validate and so on. We're open to there may be, this is a question for the community, there may be measurable components of patients' lives that are face valid. And we're open to discussing those. But I think that needs to come from the patients, the advocates, and the providers. So we're open to having those discussions for sure. Thanks.
Yeah, we're hopeful when our patient preference study completes that we'll have some good kind of rigorous quantitative data looking at that point exactly. We saw this work well with hypoglycemia when we thought about outcomes beyond A1C in the past, and we're hopeful we can kind of march down that route again here. But it's good to hear you say that. I appreciate it, Justin.
Yes, thanks.
I think it's when you were talking earlier about that, one of the things that came in my mind was that kind of number of shots per day. Certainly in the islet transplant population, I've got people who take one shot of long-acting insulin once a day, and they could not be happier with life because their blood sugars are still very predictable. And so I was thinking, hey, well, in a trial, you could use smart pens that would, log and capture those without too much laborious sort of paper or electronic diaries. I think the automated insulin delivery could make that harder in some ways. But again, I've got patients who've had transplants that were on insulin pumps, for example, before, but the hassle of wearing a pump is not worth it when you could take one shot of basal once a day or perhaps even once weekly insulin if that was going to be effective.
Alan, can I jump in and ask you a question on this point from your experience in the clinic when you're working with folks who are just diagnosed, they're put on insulin. If you're faced with this situation where you have someone who comes in, they start up insulin, they're trying to figure out all these pieces. Maybe they get treated with a DMT if one was available or in a trial, and you start to see them having all of these effects that we talk about: stability, maybe lower insulin requirements. How would you think about that notion of maybe we try taking you off insulin for a little bit? Maybe we see if you can have that window of insulin independence during the honeymoon period, or even backing off of prandial insulin doses, sticking with one shot a day. How would you kind of think about that from the clinical perspective?
Yeah, and I think we haven't really built that into the psyche. I mean, Haley described that they absolutely feel
to some degree. But we're open to simplifying trials, particularly if you have the safety to support it.
In my mind, as I was listening, I was thinking, that remission word is, we're seeing this in type 2 diabetes. There's ways that we could explore that. And I'm also thinking about, in the
Great.
transplant world, we've talked about
We're
insulin
open to
independence.
simplifying trials, particularly if you have the
Oh,
safety to
sorry.
support it.
We'll
Oh,
get John on mute, please. Thanks. The there's this definition of, insulin independence. It's the ability to wean off insulin for at least 2 weeks without any blood sugars going above a certain level. And I suppose there's part of me thinking, we could test that at different periods, or potentially we could have a sort of time to failure of basal insulin only. That might be another one. Anyway,
And
so
Justin, I just want to jump in and basically say thanks. I think you today, Lauren yesterday, have been unbelievably helpful in just the clarity of thought of where you guys are thinking about this, how you're thinking about this. I think you've made it pretty clear that you guys understand the needs that our community is facing. And next to that, you understand the challenges that it takes to design these trials, to develop therapies that help to meet those needs. So I think it's really great to see you really kind of diving in, rolling up your sleeves and helping to think through with the community here, how can we do this better? What are the ways that we can make these trials more feasible while still giving us the level of evidence we need? So just wanted to jump in and throw that thanks in there. We see you guys working with us, and we, of course, encourage you guys to continue, please, working with us on this.
yeah,
Thanks, Stephen. I appreciate the acknowledgement, and this won't be the last of me. We're rolling up our sleeves, and we're side by side with you all, and I appreciate the opportunity.
that's great. Listen, I'm going to draw things to a close. I want to just also, first of all, thank all of us, on screen tonight. Thank all the audience who are listening in. I think this dialogue is hugely helpful. In life, I've learned that it's difficult to read people's minds. And when you try, you make things up and you get them wrong. You have the conversation, it's much, much clearer what the path ahead is or will be or could be. And so I think the dialogue tonight's been really robust. I want to thank the really diverse skill sets and perspectives we've had. Again, this is a complex area. We need all of the perspectives. And I think, CPATH, thank you for hosting this. It's been a pleasure for me to be part of it. And I wish you all a very pleasant afternoon, evening, morning, or whatever's left. Over to you, Joe, for the final word.
yeah, just before we sign off, I want to let people know that we did have a brief audio glitch, but these things are being recorded, so you'll be able to watch them in playback if you missed anything. We apologize for that, but I think we're all back on audio now. So just to let folks watching know that anything you missed, you'll be able to go back and see.
Thanks, everybody.